بسم الله. الحمد لله والصلاة والسلام على رسول الله. Welcome for all to continue breast ultrasound lexicon interpretation and management second lecture presented by Dr. Rabab, consultant radiologist. Welcome, Dr. Rabab. We have to start the lecture.
Thank you, Suhair. بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين حبيبنا ونبينا وقدوتنا محمد بن عبد الله وعلى آله وصحبه أجمعين وببركته بإذن الله موفقين. Hi, today I'd like to continue highlighting viral descriptors and lesion characterization. Previously, we have discussed the breast mass, descriptor shape, margins, orientations, echo pattern, and posterior features. And sorry, again stuck. Okay. And the breast composition is also have been described earlier. And later, inshallah, we are going to discuss a non-mass as new descriptor and the special cases. Today, we are going to talk about calcifications and associated features. However, we will split them into two sessions to give more discussion, because usually most of your questions are about how to describe some abnormalities on breast ultrasound. Okay. As we have mentioned before, according to the BIRAT system, a mass on breast ultrasound is characterized by the morphology, orientation, echo texture, posterior features, and associated features. Who is going to describe this lesion? Quickly.
Irregular mass.
Excellent.
Irregular mass lesion, heterogeneous hypoechoic, with speculated margin, posterior shadow with central calcific foci.
Excellent.
Surrounded by thick echogenic halo, thick echogenic rind.
Excellent. 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 So the margins are microlobulated, combined. And the posterior features are also combined, shadow and enhancement. Okay? So here the new description is the micro calcifications. So today we are going to talk about micro calcification, about calcification on ultrasound. Calcifications in the BIRAT's 5th edition atlas list choices as follows. Okay. Early on in the 4th edition, the description of calcification was only calcification in a mass, but in the 5th edition, 2013, okay, calcifications describe or characterized as calcification in a mass, calcification outside a mass, and intraductal calcifications. What is the difference between the two images in terms of calcifications? What is the difference here? Regarding the calcifications, what is the difference in calcifications in these examples? Two examples. No one? There is no difference between these two calcifications?
The right image shows the posterior acoustic shadow in calcification, and
Excellent.
the calcification appear macro calcification.
Excellent. Who said macro
wide.
calcification? Who said the macro calcification?
أنا ومسلمة.
Excellent, Salam. Excellent. Well done. Yeah.
Thank you. Thank you.
And the other one?
The other one, the calcification has no shadow. Posteriorly, it looks like micro.
Excellent. Well done. Excellent. Well done. So
Thank you.
we have microcalcification and macrocalcification as on mammography. Okay. There are two types of calcification: small, fine calcification and coarse, large calcifications. The microcalcification are less than 0.5 millimeter in size or in diameter and are usually seen as echogenic flecks. Do not cause shadowing because they do not occupy enough of the entire acoustic beam to attenuate it. Okay? So they are sometimes indistinguishable from the noise or from the speckles of Cooper ligaments in the adjacent parenchyma. However, when microcalcifications aggregate, okay, clump together, making a larger calcifications, it might attenuate the acoustic shadowing. So it might occupy the entire beam, acoustic beam, and then can result in attenuation and subsequent posterior shadowing. As in this example, these are small foci or small flecks, bright flecks represent microcalcification. But these larger calcifications, okay, are either equal or greater than 0.5 millimeter in size. So we call it macro calcifications because are large enough to occupy the entire acoustic beam, usually cause posterior shadowing. Okay, microcalcification embedded in a mass may better be depicted at ultrasound. If the calcification embedded in a mass, so it will be easier to be visualized, especially if the mass is hypoechoic. Okay, it will give background contrast. As in this case here, there are faint flecks of microcalcification, could be appreciated. Why? Because being contrasted by the background hypoechoic underlying mass. However, microcalcification can also be well detected if they are numerous or if they are tightly grouped. Here, these are numerous as well as grouped together. That is why make it easier to be conspicuous. However, when are scattered within the lesions, it will be difficult to be appreciated. And it might be hard, okay, to be differentiated from the speckles within or an artifact within the parenchyma. Can you see these are scattered foci within this mass? Okay, but it is hard to tell if these also represent calcification or noise. Okay, still we are talking about calcification in a mass. The morphology of calcifications of ultrasound detected calcification will not be as readily discernible as at mammography. At ultrasound, we can say there is calcification or there is microcalcification. but not like in mammography. We cannot say this is which type of calcification, linear, branching, whatever, all these morphological characteristics described on mammography. Here it is difficult to further characterize based on ultrasound. However, if microcalcification associated with a suspicious mass, then the microcalcification will be suspicious, okay, as seen in this example. So these are few foci of microcalcification in this isoechoic mass, but because the mass having a morphological suspicious feature, then this microcalcification is suspicious. And generally, punctate calcifications in a mass has a predictive, or punctate calcification in general has a predictive, positive predictive value for cancer is 25%. That means in the range of BIRAT 4B, when a mass associated with microcalcification or punctate calcification, then we have to label it as BIRAT 4B, regardless of morphology. Okay? And microcalcification grouped in a segment within a mass is suggestive of malignancy. Okay? Yani it will be more suspicious if it is grouped or clumped or aggregate inside the mass as seen in these examples. Okay? Okay. However, any rules has an exception. Do you agree? And here we have tightly grouped microcalcification in a benign mass in a case of sclerosing babylon. Okay. And in this example here, we have the previous cases were my case were mine, but this example is from the literature. Okay, here we can see a large focal asymmetry in this part of mammogram. Okay, and demonstrate some fine calcifications. Okay, corresponding ultrasound demonstrate 4 centimeter mass, oval, circumscribed with diffuse punctate calcification. Okay, intra-mass calcifications, diffuse throughout the mass. So, but if you look here, because the mammogram is so dense, the calcification is more appreciable in ultrasound rather than on mammography. Okay, but as we have mentioned earlier, positive predictive value for cancer with this punctate calcification is considered to be 25%. So in the range of BIRAT 4B. Okay, so recommend biopsy. And the result was a complex fibroadenoma in this case. Though it is a benign calcification in this case, however, we have to know that complex fibroadenoma, although is a benign mass, but considered to be a high-risk mass. Okay, it has a greater risk than the non-complex fibroadenoma. The risk is about 3.1 to 3.7 times compared to 1.9 times of non-complex fibroadenoma. Okay, this is my patients. In this case here, okay, this was about 50 plus lady. She was a secretary in our department, complained of palpable lump. Okay, this is her mammography. She has here asymmetry. Okay, ultrasound corresponding to asymmetry demonstrate this parallel but irregular heterogeneous mass with intramass microcalcification. Again, microcalcification appreciated here on ultrasound more than on mammography, okay? Because the mammogram was dense. Okay, this is from literature. We have a group of punctate fine microcalcification here, tightly group of microcalcifications. Again, can you see it on ultrasound? Well, appreciable. This is a B mode ultrasound, and this is what is called micropure ultrasound. This is a calcification enhancing technique, okay? It will appreciate or will demonstrate the calcification, and it will make it easier to be biopsied, to be under ultrasound guidance. And this case was, the histology of this case showed fibroadenoma with ductal carcinoma inside. And here we can see the specimen, radiographed specimen, proven that there is a calcification within the biopsy segment taken. Okay. If we look for these lesions here, what is the difference between this is the same mass, okay? But if this is a transverse and here it is longitudinal. Can you tell me the difference? And it is written here, it is an involuting fibroadenoma. It is oval, circumscribed, and everything. But what is the difference between the two images? The calcification here demonstrates shadowing, while this part of calcification without shadowing. What does it indicate? That this is macro calcification or coarse calcification, and this is fine calcification. If we look here for the mammogram, we can see this part demonstrate popcorn coarse calcification, while this a little bit smaller calcifications, okay? And as you know, involuting fibroadenoma, the calcification start first as fine, then get aggregated, okay, and become larger and coarse. So early on, you might see this appearance, and still can be fibroadenoma going to be involuted. Okay, here we can see this mass with calcification, large calcifications, and extensive posterior shadowing. This is a dystrophic calcifications in a case of post-lumpectomy fat necrosis. So, usually macrocalcification associated with benign lesions such as involuting fibroadenomas and dystrophic calcification in scar tissue or fat necrosis, okay, as we have mentioned before. How will you grade this mass? What about these calcifications? This is macro or micro calcification?
This is macro calcification.
Macro.
What's the mass?
Macro calcification. So, how will you grade the mass?
The mass is irregular in shape.
Excellent. So here we should not depend basically on the calcifications. We have to depend on the morphology, and we have to consider the margin. As we mentioned earlier, it was the primary criteria, primary important criteria. The margin is the key. The margin is the key. The margin is the key. Okay? And then the shape. Here the shape is irregular, the margins indistinct. And there is associated calcification as well as berry lesions, hyperechogenicity, but mostly berry lesion, edema, or desmoplastic reaction. So this mass definitely is going to be graded from BIRAT 4 or above, okay? At least BIRAT 4C. This is my patients, and it was proven to be invasive duct carcinoma. So, in spite of these benign appearing calcifications, the underlying mass was suspicious. So we should not go with benign calcification and ignore the most important morphological features. Okay, the second descriptors in calcification is a calcification outside of a mass. Macrocalcification are sonographically easy to locate in the mass and outside a mass in breast parenchyma. Okay? It will be easy. Since it is macro, since it is large, causing shadowing, it will be easier to be detected wherever within a mass or outside of a mass. And this is my patients. We have here curvilinear calcification in the parenchyma with posterior shadowing in a case of fat necrosis. And this usually represent part of what? Rim calcification on mammogram, okay? Again, calcifications outside of a mass, okay? The microcalcifications at ultrasound in fat or fibroglandular tissue are less conspicuous than when present within a mass because they do not shadow or they do not give shadowing, okay? When seen within the mass, especially if it is hypoechoic, it will enhance the conspicuity of that microcalcification. But when it is seen within the parenchyma, especially within the fibroglandular parenchyma, the microcalcification are bright and the speckles within the parenchyma as also bright. Okay, speckles of the Cooper ligaments and artifacts all are bright. So it will be difficult to be appreciated unless are sufficiently numerous or tightly grouped. Okay, then they can be discerned. Okay, when small calcification within or outside the mass are seen well enough to target, ultrasound guidance may be used, and preferably using a vacuum-assisted biopsy device. For the calcification, it is preferable to use the vacuum, okay, to take the whole lesions. And it is also important or essential to radiograph the specimen to make sure, okay, the sample contain calcification. Targeted calcification is seen within the biopsied sample, okay, to verify that things essentially to radiograph the specimen, okay? And it's also important to place a clip at the biopsy site to demonstrate post-biopsy on mammography. Here we can see this area, of calcification outside a mass, okay? And it is a punctate calcification, so it is suspicious. Being a punctate calcification, whether within a mass or outside the mass, it is a suspicious. So it is BIRAT 4B. It was seen on mammography as a calcification. Ultrasound also does not show an underlying associated mass. Demonstrate again the calcification outside the mass within the parenchyma. And the biopsy result revealed extensive adenosis, a benign concordant result. Okay. Again, this image, calcification enhancing technique, okay? And this is a group of calcifications. This is the B mode ultrasound, okay? In the B mode ultrasound, only about 4 particles of calcification could be appreciated. So it is difficult to be biopsied. But with this technique, micropure technique that enhance the visualization of calcification, could demonstrate 12 particles of microcalcification, so facilitate, okay, ultrasound guided biopsy as seen in this case. Okay, so the SER descriptors of calcification is intraductal calcifications. And intraductal calcifications per se considered as suspicious. Okay, here we can see soft tissue with calcifications, though here the calcification also a little bit large, but still, since it is intraductal, it is suspicious. And this is my patient proven to be bilateral intraductal papillomas. This is also my patient's, okay? Her mammography demonstrates segmental fine polymorphic calcifications. Corresponding ultrasound demonstrates segmental ductectasia with intraductal punctate calcification, and biopsy proven extensive DCIS. This is a case from literature demonstrate intraductal calcification. If you remember the anatomy, you see the ultrasound lectures of anatomy, and these oval, we said oval isocoic structures, oval or elongated isocoic structures within fibroglandular parenchyma represent lobules and ducts, okay? And here we can see these structures, isocoic structures, and we can see within these structures a bright hyperechoic flex representing intraductal calcifications. And being intraductal calcifications, it is a suspicious findings for biopsy. And this case, it was a case of a DCIS, okay? The extensive intraductal component of invasive ductal carcinoma, even there is, okay, sorry. This is DCIS because DCIS component of invasive cancer seen here, okay? This is a mass, underlying mass representing invasive cancer, and this component, intraductal component, or DCIS associated with invasive ductal carcinoma. And this example also from literature, here we can see segmental powder-like, faint or fine calcification, but being segmental, okay, is suspicious, and corresponding ultrasound demonstrate ductal dilatation, irregular ductal dilatation with intraductal fine calcification in a case of solid DCIS. And here we can see again intraductal calcification, biopsy proven high-grade DCIS. It is difficult to say ductal, but the distribution of which, why it is enlarged, the duct is enlarged, okay, and soft tissue, the calcification embedded in a soft tissue filling these ducts, okay, and the biopsy proved DCIS grade 3, high grade DCIS. And here we can see, okay, sorry. I supposed to forget it, okay. Here we can see that a high resolution transducer are currently used to improve the detection and characterization of intraductal calcification. If you look which one is more conspicuous, the calcification more conspicuous and more delineated in which image? Which one demonstrate better delineations of the calcification in these two images?
Image B.
Image B, yes, excellent. Image B. It is obviously in image B, the anatomy, ductal anatomy, as well as the calcifications are well delineated and appreciated. Why? Because of higher frequency transducer. This is 17, while when we compare it with the lower transducer 12, it gives us a better resolution of calcification particles. Okay. We complete the calcifications. Now we are going to talk about associated features, which is the new section in the 5th editions, okay? Not 6th, the 5th edition, 2013, okay? It is the effect of the mass on its surrounding, okay? The mass either not to affect the adjacent tissue, or it may cause some sort of effect in the surrounding tissue, which can be seen as architectural distortions, okay, with disruption of tissue plane or Cooper ligament chains, ductal chains, skin thickening, skin and nipple retractions. In addition, these we are going to talk about which today, okay? And in addition to edema in tissue, and also effect of vascularity in a lesion, is it present or is it absent? And if present, is it inside or outside the mass? And the elasticity assessment, whether it is hard, soft, or indeterminate, we are going to talk about in the next week's session, inshallah. And number 7 is the echogenic rind. This associated feature is newly added to the ACR Atlas in the 6th editions, in the latest editions, okay? We are going to talk about which in the today's presentations. Okay, architectural distortions. Architectural distortion is one of the mass effect on the adjacent tissue and may be manifested by compression of the mass into the adjacent tissue, or might result in disruption of tissue planes and echogenic rim, distortion with a lack of tissue differentiation due to the surrounding edema and desmoplastic reaction, straightening or thickening of the Cooper ligaments, or we can say Cooper ligaments changes, obliteration of the tissue plane by infiltrating lesions, and abrasion of ductal patterns. If we look for these masses here, the two examples, we can see almost all these descriptors can be applicable in these cases, okay? In these two cases here. Okay. This illustration is more applicable in mammogram, okay? But can still work here in case of ultrasound, okay? Sorry. Okay. Let us see the illustration. As you know, normal breast structures are overlapping. The fibrous band, the Cooper ligaments, ducts and vessels are overlapping, creating intersecting slide paths that may mimic the architectural distortion on mammography, not here. But the principle is the same regarding that the overlapping of this structure never actually radiate to a central point. Look here, okay? Haphazardly overlapping. They should never radiate to a central point like this. If it occurs, okay, if it occurs, this we can call it as an architectural distortion whenever seen on mammography or on ultrasound. Normally, lines extend through and beyond the center of quiescent findings. If we have lesions or any questionable area, and we can see these lines radiating through without pointing to a central point, then it will not be a true distortion. But if it is pointing to a central point, as in this case, you can see here, all structures pulling to a central point, that we call it as an architectural distortion, or this is the pattern, interesting pattern of an architectural distortions. Okay, let us see these examples. Let us simulate this plant with the breast parenchyma. If we look here, we can see this shrubbery, okay, normal shrubbery. We can consider it as the normal parenchyma. Throughout, it is the same, except for this area here. Here we can see different leaves. These leaves are a little bit sharp and pointing, okay, toward the center, or extending or radiating from a single point, okay? This obviously looks different when you see this This looks different, okay? So this represents a distorted area compared to the all similar structures surrounding it. So this analogy to real life ultrasound of the breast. If we look here for this ultrasound of the breast, the parenchyma, this is the residual parenchyma here and here. But if we look here, what we can see what? There are a lot of hyperechoic bands or pride bands of tissue interdigitate between the fat and point altered, okay, and seem to be radiate around this hypoechoic small lesion here, okay, giving an architectural distortion, deviation from normal, abrasion from a normal. This is not normal. The parenchyma here and here, not like here. So this is same as this leaves, okay? Abnormal leaves. Abnormal because it is not similar to the surroundings. This is also not similar to the surrounding. This, and even if you look here, if we look for the parenchyma, it's supposed to be like this. This even extends beyond the contour of the fat glandular interface into the anterior subcutaneous fat or in the pre-mammary zone. So it represents contour abnormality, focal angulation, retraction, distortion of the edge of the parenchyma with straightening and thickening of the trabeculae, and which is also disorganized. Okay? Let us see this example here. What we can see here, again, definitely this area is abnormal. I cannot see a real mass. I can't see real mass, but definitely this is a not normal parenchyma. We have seen hundreds and hundreds together. We can see together hundreds and hundreds normal parenchyma in sonographic anatomy lectures. Does it normal parenchyma look like this? Definitely no. So this is not normal. There is deviation from normal. There is disruption of tissue plane. It differs from normal. The tissue is distorted. How it distorted? It is blurred. It is fuzzy. It is abnormal color, abnormal shape, disorganized. Okay? So if I simulate it with this tree, again, here I can see the leaves are green, okay, and have a normal shape. But these areas definitely look different from the normal, are black and are clumpy, okay, clumpy like that, are clump and black. So this is the same, this area are black than the normal parenchyma and clump, not a mass, but area clump and deviated from the normal. When this is my patients, when I angulate the probe, okay, in the same area, I could appreciate an speculated irregular hypoechoic shadowing non-parallel mass, okay, with hypoechoic spicules. Why these hypoechoic spicules? Because the background is hyperechoic parenchyma. So we have hyper and hypoechoic spicules. When the mass within the pride parenchyma, you can see the hypoechoic spicules, okay? And also here, look for this fuzzy hyperechoic reaction around the mass, obscuring and distorting the adjacent tissue, okay? And in this example from literature, you can see here what we can see. Long spicules, hyperechoic spicules, okay, tethered and pulled by the mass. Why I can see it as hyper here, the spicules? Because the background parenchyma is fatty, okay, contrasted black. When you have a black background, you will appreciate the hyperechoic spicules. While if you have background fibroglandular pride parenchyma, you could appreciate, okay, or you could see the hyperechoic spicules. And here we can see what these are straightened, the Cooper ligaments straightened, thickened, tethered, and pulled by the mass. And these are highly suspicious features. When present, we know that we are dealing with a higher probability of a malignant lesions, okay? So it is a strong predictor of malignancy. Okay, what about this image? Here we can see a contour abnormality again. Okay, if I look here, look for the parenchyma, this is a contour. This is a contour of fibroglandular fat interface. When we come to this area, the contour is disrupted. Again, here the contour is disrupted. How it disrupted? Okay, there is what? There is angulations. It is distorted. The edge is distorted with focal angulation. I have focal angulation of the parenchyma. I have focal angulation of the parenchyma. The Cooper ligaments are thick, distorted, okay, straightened, disorganized, not passing in a normal directions, in normal shape, okay? And there is underlying shadowing mass seen here in a case of DCIS. Okay. What is the difference between these two images? I can see subtle architectural distortion with altered echogenicity here. I don't know if it is real or just the parenchyma like that. How can I make... Excuse me, would you please close your mic? There is a background noise. Okay, we said that there is a subtle architectural distortion. So when they applied harmonics, this is from a literature, okay? By applying harmonics, now the subtle architectural distortion become more conspicuous. So you can use harmonics if you have subtle lesions suspicious of architectural distortion, okay? Not only that, you can give more compression and probe angulation. If the changes persist, that means it is a true architectural distortion, not just artifact or something like that. Okay, what is the difference between these two images regarding the architectural distortion? Which of these images demonstrate, okay, a better architectural distortion? Which one demonstrate a better architectural distortion? A or B? Huh?
B.
Excellent.
B.
Excellent. Excellent. Yes. B. What do you suggest the difference between the two?
I suggest frequency, changing in frequency of the
Excellent. 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 Well done. Excellent. Yes, this is 7.2 megahertz, while this one 14 megahertz. Okay, so with 14 megahertz, the architectural distortion is well appreciable, clearer, very conspicuous. The Cooper ligaments, okay, straightening, tethering, and well delineated, and the indistinct margin well seen with the higher resolution transducer. Okay. Also, here we can see an automated ultrasound, okay, image showing very nicely the architectural distortions around a malignant mass. Here we have multiple multifocal malignancy, and this is here the nipple. This is the coronal view. This is an axial and sagittal reformatting. Okay, 3 reformatting of an automated ultrasound. Okay, demonstrating multiple multifocal malignancy. This is the corresponding lesions, the larger lesions seen here. Okay, and this is the smaller one. Especially the coronal view, allowing more accurate assessment of the tumor margin and the adjacent architectural distortion. Nicely demonstrate the spicule, long spicule seen as hyperechoic lines radiating from the mass because the background is fat. That is why accentuate the visualizations of the echogenic spicules rather than the hypoechoic spicules seen extending from the mass, okay, and the distortion of the adjacent parenchyma. Okay, this is my patients. Can you see here? Where is the cursor? This is a primary breast cancer seen just below the clavicle. Okay, she has a palpable abnormality just below the clavicle. Okay, demonstrate this irregular hypoechoic mass with radiating hyperechoic lines or spicules. Look for these hyperechoic because surrounding area is fat, and disruption of tissue plane. Can you see the disruption in the tissue plane here? Okay, and the surrounding, there is increased echogenicity, fuzziness, likely due to desmoplastic reactions and perilesion edema, which is seen as a non-uniform increased echogenicity around the mass or the echogenic rind. Okay, can you see here the cut in the tissue plane? Okay, here we can see this distortion, architectural distortion or disruption of normal anatomic planes with predominantly Cooper ligaments changes are destroyed and disrupted by these masses. If you look here, you can see how are thickened, straightened, and disorganized, pulled by the mass, pointing toward the mass. Again, seam is here, and look here, are tethered and pulled toward the mass in almost 4 examples. Okay, are disorganized. Normally, the Cooper ligaments, as we have seen in the lectures of the anatomy, the Cooper ligaments has an arc shape, a smooth arc shape, okay, and not very thick, okay, a band, thin band of hyperechogenicity or with arc shape, okay, and also we can see here the tumor crosses, cross the tissue plane, if you can see here, this is, this is a tissue plane. The tumor cross the tissue plane. Not only that, are protruding. There is protrusion of the tumor beyond the contour of fat glandular interface. Okay, all these are my patients. Again, this is my patients. Nauras, are you there, Nauras? Okay, do you remember this case, Suhair? This is a very old case, okay? It is almost sub-centimeter. It is maximum dimension is 8 millimeter, 8 by 6, okay? Here, this is a zoom of the lesions. Can you see here the cutting sign, okay? This is a tissue plane, and this, though it is a small mass, but cutting the tissue here in the deep margins. And depending on this sign only, okay, we report this mass as BIRAT 5, and it was proven as invasive cancer, okay? Because this, specifically these signs, okay, I found that it is really highly predicting for malignancy. Whenever we see this sign, we really have to be concerned about malignancy. As you know, there are some overlap between benign and malignant lesions, especially when are small. Might be difficult to differentiate if it is a benign one or a malignant, or even it can be just of a mild or borderline suspicious features. But these features indicate the mass is very aggressive and point to be a malignancy from my experience. These also my patients, okay? This is 1 centimeter cancer, invasive cancer, and this is also sub-centimeter, 7 millimeter cancers. But look for this cutting sign. Sometimes you might see granulomatous mastitis, you might see sclerosing adenosis, all these simulating are mimickers of cancer. But when you see the cutting signs, believe me that is highly, it has a high probability of being malignancy or of malignancy. And even as I mentioned for you, I have mentioned to you before, I have sub half centimeter. I have 3 by 4 millimeter screening, a lesion on screening imaging. It was subtle distortion on mammography. Corresponding ultrasound demonstrate 4 by 5 millimeter non-palpable mass. Okay, it was oval, appear at the beginning. At first glance, it seemed to be an oval mass, oval hypoechoic, but when sweeping around the margin, I could appreciate small area of cutting through the tissue plane. And at that time, we call it a cutting sign, okay? And according to these signs, I reported as highly suspicious of malignancy, and it was proven to be an invasive duct carcinoma, okay? So really, you have to consider these signs. The cutting signs is really highly suggestive of malignancy. This is the only signs I found, depending on a single sign to say this is most probably malignant. This is the cutting signs. Even the speculation, though it's highly suggestive of malignancy, Okay. Sometimes sclerosing adenosis, radial scars, and these post-surgical scars, and these benign lesions might give an speculations, but I have never seen a benign lesions giving these cutting signs or cut through the tissue plane. Okay. Again, talking about the architectural distortions. Here, this example, also these my patients, you can see obviously this example cutting through the tissue plane. Here, you can see the cutting, okay, through the tissue plane. This is also cut the tissue plane, and there is surrounding, okay, hyperechoic. Not only that, the distortion here, including the skin. There is the V-shaped retraction or pulling of the adjacent skin, also can be considered as an architectural distortions. And here you can see change in the Cooper ligament, pull toward thickened and pull toward the mass with these echogenic radiating spicules. Architectural distortions. This is obviously an irregular hypoechoic or deeply hypoechoic mass. Can you see the cut in tissue plane here? This is also my patients. Again, can you see the cut in tissue plane? So these all are invasive duct carcinoma presenting with architectural distortion, specifically cutting signs. Again, here we can see these two irregular hypoechoic non-parallel masses. In these two examples, bulging from into the tissue, into the pre-mammary zones, okay, beyond the contour of fat glandular interface. But even benign tumor can bulge, okay, beyond the contour. But while bulging, are cutting the surface. Can you see the tissue at the interface here is being cut by this mass? This is the most suspicious features. Cutting the tissue plane while bulging. And this also while bulging, okay, cutting here the tissue plane, and the Cooper ligaments are tethered and pulled by the mass. Disorganized, okay, straightened, disorganized, pulled by the mass. So all features suggestive of or highly suggestive of underlying malignancy. If I look for this example, any rule has an exception. Yes, I can see here a hyperechoic mass-like lesions, okay, bulging in the beyond the contour of fat glandular interface into the pre-mammary zone or subcutaneous fat, with thickening and pulling of the Cooper ligament. But this case, it was just a fibrous ridge, and it was stable for at least 3 years on follow-up. My patient also. This is my patients, okay? Here we can see a contour abnormality. Again, contour abnormality, we consider it as an architectural distortion. And this patient have presented by a palpable abnormality. And the site of the abnormality at the first glance, we have seen this fibrous ridge. And some shadowing is seen here. It can be from the Cooper ligament. But we have to consider the clinical. And as I have mentioned for you in the lectures of technique, you have to put your finger below the transducer to make sure that, okay, you are in the same place when things. You have to ask the patient to point by her finger where exactly. And you have to correlate the size and shape under your finger, okay? And correlate it to the ultrasound image. What I was what I had felt under my palm, under my finger, sorry, was not corresponding to this small pointing, okay, tissue. So I swept, okay, through this area looking for underlying lesion, and I could appreciate this benign appearing mass, and it was proven fibroadenoma. So that is the palpable abnormality. If you look here, the palpable abnormality size-wise not corresponding to this one. This one you expect to palpate smaller, okay, and sharper, not like this one. Okay, again, here I have example of a benign abnormality giving contour architectural distortion. In this example here, this is the fat glandular interface. Fat glandular interface in this example. I can see our architectural distortions. There is something bulging from the fat glandular interface. There is a lesion, hyperechoic lesion with patchy central area of hypoechogenicity bulging into the pre-mammary zone or beyond the fat glandular interface in a case of fat necrosis. This is my patients. While this from the literature. Here we can see what? We can see this angular margins along the contour of fat glandular interface in a case of granulomatous mastitis. So any rule has an exceptions. That is why there is no sign 100% indicate benignity or indicate malignancy. Again, here we have multiple examples of benign causes of architectural distortions. These my patients, these my patients here. This is two examples of fat necrosis, causing. Look for the Cooper ligaments coming here toward this anechoic thick wall mass, and the seam here, the surrounding blared tissue with lack of differentiation due to the perilesion inflammation and reactions. And this is a granulomatous mastitis mass, heterogeneous, with surrounding reactions also result in lack of differentiations. But if you look here, the tissue is not sharply cut. It's merged with the wall of the lesions. And this case is a silicon granuloma, sclerosing papilloma, and radial scar from the literatures. Okay, I think, I don't remember exactly, but I think this is my patients, the sclerosing papilloma, but these are definitely from the literatures. Okay, again, another examples of benign architectural distortion from the literature in a case of granulomatous mastitis. Can you see the lesion here? And can you see the adjacent reactions, the Cooper ligaments pointing toward the lesions and blaring of the adjacent tissue? So there are many examples of sonographic architectural distortion due to underlying benign etiology, including complex sclerosing lesions, sclerosing adenosis, fat necrosis, post-procedural changes, granular cell tumors, breast fibromatosis, post-surgical scar, post-infections healing, healing of trauma or acute trauma even, and biopsy can also lead to architectural distortions. Okay, this is my patients. Can you tell me how you are going to grade this mass? Is it going toward benign or toward malignant, and why? Huh? What do you suggest?
They must look
Is there any architectural distortion? This is specific questions. Is it associated with architectural distortion or no?
associated عامل pushing للفاشيا downward.
Okay. So fibroadenoma can give a mass effect. We have seen before a benign masses giving just a smooth mass effect.
Okay.
So do you suggest it is a benign, or it was a challenging, really, this case, one of my challenging case, but fortunately at the end, okay, God helped me and opened my heart and eyes, and I could grade it. I could grade the lesion correctly. So what do you expect after this introduction? So at first glance, I thought that it might be just a benign lesions, okay? But I told you before, the margins, or the margin is a key. The margin is a key. The margin is a key. Okay. What about the margin of this lesion? Is it circumscribed?
Indistinct margin.
Yes, it is indistinct margin. Why it is only indistinct? It is indistinct. And
Microlobulated.
there is faint echogenic rim. Okay, there is, and the echogenic rim is non-uniform, the thickness of which at one point is thicker than the remain. So make me unhappy. And if you look here, there is subtle cutting here. Yes, here it seemed to be bush, but in the other side, you see there is faint area of cutting sign. And it was proven to be an invasive cancer. You can compare it with this fibroadenoma, though this fibroadenoma is rounded, okay, and it has to be biopsied. It's not a typical one because it has indeterminate shape. The rounded is not reassuring, but it was proven fibroadenoma. It was my case, okay? But look for the effect into the adjacent tissue, okay? It is pushing, giving some compression on this. Is, yes, this is considered to be architectural distortion, but of a benign nature, compressing the surrounding tissue. While this one, okay, obliteration. This is compressing, but this is obliteration. We cannot make, okay, exact difference between the normal tissue and abnormal tissue here in this, okay? Between the normal parenchyma and the lesions, there is no abrupt border, okay? Because there is infiltrations of the lesions around, okay, in the adjacent tissue, make it hard to appreciate an abrupt delineations of the margins. So we are dealing with echogenic rind, the additional terminology to the associated features added in the 6 editions, the latest edition 2023. So what is echogenic rind? We have discussed it before, but we are going to revise it again. We have discussed it in the margins. Now we are going to discuss it again because as an associated features, okay? As a descriptor in the associated features. We can compare the previous case, my case, to this one. This also, it was a challenging case. It appeared on mammogram. This lady was 28-year-old, 28-year-old. And I will show you the whole case, mammography and ultrasound in the coming lectures, okay? Her mammogram revealed an oval mass, and she was only 28, but because of ultrasound, is non-parallel and this hyperechoic rind, okay? And there is retraction. Look for the skin retraction here, okay? So I reported as a suspicious by RAD4C, and it was proven to be an invasive duct carcinoma, okay? Okay, this is also, for example, of my patients with echogenic rind. Can you see the echogenic rind varies between this, and this? But look for the cursor, for the marker. Look here, this lesion, it was at the mid-axillary line. This one, it was at the axilla. Again, this is at the axillary tail, close to the axilla. And this in the midline, almost, okay, near to the midline. And I have shown to you the previous example where the lesion was in just subclavicular region. All these cases, what is the teaching point from these cases? What do you suggest the teaching point? It is related to the technique. The teaching points that to remind ourselves while scanning the patient, we should scan superior to the clavicle, medial to the midline, lateral to the mid-axillary line, and include the axilla so as not to miss small cancer. Okay, let us go back to our descriptor, the echogenic rind. What is the echogenic rind? As we have mentioned, early in the 4th edition, okay, historically was a hyperechoic halo. In the 5th edition, okay, the descriptor, the corresponding descriptor, changed to echogenic rim, and in the 5th edition is echogenic rind. Okay, it is a thick band surrounding the mass. Okay, and it will make hard to determine exactly between the transition between the mass and the parenchyma. This is the illustrations, this image from the literature. You see, early on, it was a hyperechoic halo, but no more use hyperechoic halo. Now it is a hyperechoic rind. Okay. it is of non-uniform thickness, okay? It is usually surrounding hypoechoic mass of variable shape, as we have seen, some of which just an oval shape, but with this rim, and it can be irregular, can be rounded, whatever, okay? This thick band of various degrees, as we have mentioned, and of echogenic tissue surrounding all or part of the mass, and likely represent desmoplastic reaction or peritumoral edema or spicules that too small to be resolved by ultrasound. If we have seen here in these two examples, the echogenic ring almost completely encircled this malignant mass. But in the other example here, we can see this is the line follow the hyperechoic rind, and as we have mentioned before, we said that it is thin or relatively thin anterior and posterior, but thicker on the edge or on the side. Can you see it, how it is thick here on the side? But in this example, it is incomplete. Posteriorly, there is no hyperechoic rind, but the lesion itself, it seemed to be, okay, angulated and infiltrating into the adjacent parenchyma. So this lesion, we have these portions react different from this portion, and this indicative of heterogeneity of breast cancer even within the same lesion. Within a single lesions, we could find, or we can find, heterogeneity of the breast cancers. So, echogenic rind introduced in the 6th edition as a new element in associated features. And as we mentioned, just to remind you, it can be due to edema, due to desmoplastic reaction, or spicules beyond ultrasound resolution. This reaction disrupts the texture of normal tissue around the mass, okay? It is considered an architectural distortion. It results in lack of differentiation of normal tissue around the mass, okay? And as we mentioned, it has a high predictive value for malignancy approaching 74%. So it is in the range of 4C. If even benign morphology with echogenic rind, we have to grade it as BIRAT 4C. Okay. Just to compare it, or to compare it with the pseudocapsule surrounding fibroadenoma. Can you see the pseudocapsule? And can you see, this is my patient, those both my patients. Here, confidently, we can label this as, if it is the first time, as a probably benign mass, okay? And this is as highly suggestive of malignancy, okay? This is an oval, parallel, homogeneous, hypoechoic, okay? This posterior enhancement and presence of these thin capsules. It has a high predictive value, high negative predictive value, okay? As we mentioned earlier, approaching 98, okay? But the presence, negative predictive value, but the presence of echogenic ring, regardless of morphology, have a predictive value for malignancy of 74. Okay, how we could differentiate between the two? This one is thin, as you have seen here in the illustration. It has to be complete. We have to make sure it is complete. It is thin, it is uniform. completely surrounding an oval lesions, while the echogenic rind is what? A thick, variable, indistinct, not sharp, indistinct, non-uniform, can surrounding the lesion completely or incompletely or partially, and what else? It is surrounding variable shape of the mass, not necessarily surrounding certain shape or certain type of a mass. Any type of a mass surrounding with this echogenic rind, it will be BI-RAD 4. Then we will add the suspicious features according to the morphology of the lesion and orientations and other features of the lesions. Again, here we can see the difference between more examples to differentiate between the rind and pseudocapsules. Okay, this is the pseudocapsules here, very thin, uniform, completely surrounding, and this you might say it is relatively thin, but it is indistinct. It is not uniform. It is not sharp. It is not pencil-like. You see, you can see it here. Here it looks thin, but here a little bit thick. Here thick. As we mentioned, that at the side it is thicker. Again, here this is echogenic rind. Another example, look how it is thin, uniform, the capsules. Okay, here we said that the rind is less sharply demarcated, hyperechoic zone, thicker, more variable in thickness, okay, not uniform, surrounding mass of any shape, and associated with distortion because it disrupts the normal texture in the surrounding mass. While the capsule, thin or pseudocapsule, thin, hyperechoic uniform line, completely surrounding an oval, benign appearing mass. Look how it is thick here. This is relatively thinner, okay? So the underlying mass here is obviously suspicious, but if you look for this one, and you can see this, you might say this is something, no, it might be, but the capsule surrounding the whole lesion, it was proven that a fibroadenoma. Okay, what about this here? I can see here small hypoechoic, but I can see large hyperechoic, larger hyperechogenicity with centrally small hypoechogenicity. What does it mean? How I can report this? How can I call this? Okay. Both are invasive, both are my patients and representing invasive cancer. So this is the nidus, okay? This is the cancer nidus, and all these represent a reaction. This is the rind, the hyperechoic rind. All this is a hyperechoic rind. But any rule has an exceptions, okay? We have to consider fat necrosis as strong mimickers of breast cancer, can represent the same hypoechoic surrounding large area or large area of hyperechogenicity with areas with patchy hypoechoic area within. But at the end, it is BI-RAD 4C at least. It is BI-RAD 4C, okay? And even here, presence of the skin reactions without underlying remarkable inflammatory hyperemia, and so this is will make it more suspicious and can upgrade it to BI-RAD 5 here. But here at least it will be BI-RAD 4C until proof, unless there is corresponding mammographic findings that suggest fat necrosis or any features that, or MRI features that saying this is a fat necrosis, it will be by RAD4C and for biopsy and pathology diagnosis. So the teaching point, when we see any hyperechoic lesion, especially if it is ill-defined, we should look through the entire lesion to make sure it is uniform. It is uniformly hyperechoic. We have to exclude any central area hypoechoic focus that might represent a nidus of breast cancer, surrounding by a large hyperechoic rind, as in these cases, okay? However, we should always correlate carefully with the clinical and mammogram to consider the common breast cancer mimickers such as fat necrosis. Here I have these two examples with echogenic rind in case of fat necrosis. Another example here, these patients also have a fat necrosis. Look for the large echogenic rind and central low density, low echogenic area. And this is also my patients. You can see the surrounding rind and central mass in a case of granulomatous mastitis. So we can see that is why it is only 74%, not 100%, because we have but less percentage of benign lesions can be associated with echogenic rind. Okay. And here we can see another two examples from literatures, okay, of a benign etiology of thick echogenic rind. In this case, it was the breast abscess. And the other example here, we can see central cystic area surrounding with a large hyperechoic area in case of organized hematoma. Okay, we completed the architectural distortion and echogenic ring. Now we are going to talk about duct changes. Okay. Here we have a mass protruding into adjacent ducts. The mass protruding into adjacent ducts, and this we call it as ductal extension. It is a highly suggestive of malignancy. If you look for the ducts, is irregular in caliber, lacking the anechoic fluid filled content, and as we mentioned, that extend from a malignant mass. So this is ductal extensions. Okay. As you know, and as we have mentioned before, that the normal ducts are anechoic tubular structures, okay, with regular smooth margins and parallel in course, okay, in radial direction pointing toward the nipple, okay, and are slightly prominent at, under the nipple, and are prized and getting smoothly narrowed, okay, or progressively narrower in caliber while pointing and going toward the parenchyma. This is the normal ducts. But if you look for this example, definitely these are not normal ducts, are not having these characters. These ducts are interruptedly, focally, okay, irregular in caliber, lacking internal anechoic, okay? And if we look here, there is adjacent mass, are adjacent to this highly suspicious mass. So these are highly suspicious duct changes. Again, this is ductal extension because here, these are my patients, all are my patients. This is an irregular mass proven to be cancer, and here we can see this extension presenting as an irregular hypoechoic dilated ducts going down toward the nipple, where you can see here, can you see this? The duct opening is also dilated, which mostly signify involvement by the underlying cancers. Another example of ductal extensions with the long ducts down to the nipple. Okay, can you see the duct extending here from the malignant mass, and it is irregular. Okay, it is dilated with an intraductal mass, and the mass is even vascular. Okay, there is internal vascularity within the ducts. Indicate, and here the vascularity extending into the nipple, which is enlarged and is asymmetrically enlarged at the site of ductal extension. From here, we can confidently say that the nipple areolar complex also involved in this case, and all these findings are important for the management of the case. This is here we can see duct extensions and what is called branch pattern. What is the difference between the two? I can see this is also my patients. This is a malignant mass, proven invasive duct cancer. Here I can see an irregular duct with soft tissue component extending toward the nipple. This is, we call it duct extension. But in the other directions, we can also see ducts extending from or toward the mass, okay, with the same features. So when the duct extends in a direction away from the nipple, then we call it branching pattern, okay, or branch pattern. So this is the mass here invading the adjacent ducts, which appear as irregularly dilated and have same echogenicity as the mass indicating ductal extensions. And in these examples here, this is the same mass, but all these images represent different directions of ductal involvement, okay? These ducts are invaded by the mass and are irregularly dilated and even branching, and with periductal edema, okay, as well as associated small multifocal tumor adjacent to these ducts. If you have seen, if you could not see even the ducts, but you can see small satellite nodule adjacently, this is most of the time represent ductal extension. But when in different directions, not only toward the nipples, it's different from direction of the nipples. As we mentioned earlier, we call it as branch pattern. And here the branch pattern are multiple projections from a mass within or around the duct extending away from the nipple, usually seen in large tumors, and has a positive predictive value of 30%. Okay. Duct changes. Not all duct changes are malignant. We have the benign duct changes much more than the malignant duct changes. And duct ectasia is the commonest duct changes we have seen in the practice. And sometimes even these duct ectasia can be just a physiological process in postmenopausal women, as we described earlier in the sonographic anatomy. We have mentioned that in postmenopausal, after involutions at the beginning, okay, the ducts, due to fibrosis, it will get dilated, okay, and lately the duct itself involuted and fibrosed, attenuated, and disappeared. If you remember that. So at one stage, as a normal physiological process, we can see a ductal dilatations. So not all ductal dilatation has a clinical significance unless the patient has symptoms. In this case, and can be, it can present, the ductectasia can present with pain, can present with nipple discharge, all type of nipple discharge, okay, can be associated. Even the bloody nipple discharge can be associated with just non-malignant ductectasia, okay? We have seen all these such cases in our practice. In this case, this is my patient. She has mild ductal dilatations in both sides, being symmetric, okay? So, and smooth, and with normal tapering, okay, toward the, from the nipple, from the base of the nipple going toward the parenchyma, without evidence of intraductal component. So is reassuring, and we report it as just a mild simple ductectasia, okay? So the features of ductal dilatation that are concerning and may warrant biopsy include unilateral duct dilatations or focal ductal dilatation in a breast with or with otherwise normal sized duct, only single duct, a solitary duct, okay, or focal duct. A dilated duct that is not anechoic, a complicated type, okay, if there is internal component, not fluid filled ducts, okay, with nodularity, with wall irregularity, wall thickening and irregularity, with indistinct margins or other suspicious features, okay? Or if there is, or if the duct extending or adjacent to a malignant mass, then it will be suspicious. This is my patients. Here, there are multiple cases, 3 cases with dilated ducts, okay? But these ducts lacking the fluid filled content due to fine internal echoes. These only fine internal echoes, and this is only demonstrate mild periductal vascular echoes due to mild inflammations, and this is just a complicated ductectasia and has to be assessed as a probably benign for short-term follow-up. The first simple ductectasia is BIRA 2. The complicated ductectasia, it is BIRA 3. And this example, also my patient, 70-year-old lady, presented with left breast lump for 20 years. This lump for 20 years, okay? And even if you look here, it's causing a mass effect into the adjacent skin. And it is intraductal component, you see? It is intraductal, homogeneous solid non-vascular mass, okay? And this is just a tumefactive solid debris, okay? In a chronic ductectasia. This is my patient. She has, I think it was a nipple discharge or so. And here we can see dilated ducts, okay, with intraductal component. So we need to know what about this intraductal component? Is it a soft tissue, or is it the debris, or what? Okay, sometimes it's really challenging and difficult. In this case, fortunately, it was a non-vascular. The intraductal, the vascularity are peripheral, rim vascularity. There is no vascularity related, but it doesn't exclude soft tissue component. Lack of vascularity, okay, does not exclude that lesion is not a soft tissue. But fortunately, okay, that lesions was mobile. If you look here, it doesn't attach to the wall. This is one reassuring. And at the same time, by changing the position of the patient, this ball change its position, okay, or its location within the duct. It moves. That it was helpful to us. Okay, if the lesion is floating, that means it is a debris, not a soft tissue. If you are confident not attached to the wall, okay, in all direction, because it might attach from this side, but not attach from the other. But if it is the most reassuring, if it is moving, this is most reassuring. So just I give the patient follow-up, and it shows even regression in size in long-term follow-up, and that indicate that was downgraded to BIRAT 2 from BIRAT 3 to BIRAT 2. Okay, and just it was a tumefactive sludge inside the duct. So sometimes these type of lesions seen low or fat density on mammogram, sometimes, because sometimes represent a fat particles or lipoproteins, okay, that can give lower density of corresponding mammography, okay. And as you know, we would like to avoid unnecessarily biopsy, and at the same time, we need to avoid missing cancer. That is why we have to weigh things. Okay, this is my patients also, okay. Here you can see the attachment. Can you see the attachment? This is a ball surrounding with fluid here, but at this location, this is at this location, and these lesions also here attached to the wall, was not moving, okay. And these are soft tissue, though they didn't show vascular echoes on Doppler. The image is not available now, but the patient was presenting with nipple discharge and reported as suspicious for biopsy, and was proven to be multiple intraductal papillomas. And if I remember, bilateral, I think. And this is, you have seen in the calcification earlier, okay. I brought it for you as example of calcification, of intraductal calcification. Intraductal calcification per se is suspicious, regardless of associated soft tissue masses. So here, can you see here, this soft tissue mass? This is the right breast, and here in the left breast, and this assessed as BIRAT 4 for biopsy and proven to be bilateral multiple intraductal papillomas. This interesting case, there is a ductal change. Here we can see a ductal change, okay? But can you see this ductal change? And even here, associated with retraction of the nipple areolar complex, okay? But, and lack, it's also lack of anechoic fluid filled ducts, but it demonstrates the normal tapering, okay? And it's surrounding with this hyperechoic, and the skin is also shaggy, irregular, and hyperechoic. And you can see here the duct attached to this skin, okay, but with hyperechoic wall tethered toward this. There is no soft tissue component and there is no internal vascularity. And this it was a long-standing process. Okay, so this is the case of a periductal mastitis. It is inflammations of the tissue around the ducts, usually under the nipple. Okay, and it becomes inflamed and can be infected. And this is usually seen at young age, though it can occur at any age. Okay, of unknown etiology, risk factor is smoking, okay, and not related to lactations. It has no relation with lactations. The lactation or the peripheral mastitis is different from the periductal mastitis. It's a non-peripheral mastitis. This is a periductal, and it doesn't increase the risk of developing cancer. Most cases of periductal mastitis treated by antibiotics, and the surgery reserved for non-responding or complicated cases with or recurrent cases. Okay, this is my patient also. But what is the difference between this and this one? What do you think about this one? Are you going to report it as just ductal mastitis, or you will say this is a suspicious ductal changes? Definitely, it is a suspicious ductal changes. Definitely suspicious ductal changes. Why suspicious? The very things, okay, look for the directions of the ducts. Lack of normal arborizations. This is a normal arborizations. The ducts, okay, when it's supposed to be relatively more dilated at the base of the nipple and tapered with smooth narrowing toward the parenchyma. This is demonstrate the reverse. The reverse. This only signs is suspicious. Okay, indicates something from the parenchyma extending through the duct and expanding each gradually. Okay, the more close the area is more expanded. There is something, and it is tortuous, and the surrounding tissue, look for the surrounding, is distorted. There is edema, there is skin thickening, there is no delineations, okay, of that. There is lack of differentiation, complete lack of differentiation in the adjacent tissue. And then if you can go down, you might find a mass or something, and even it is a solitary duct, okay? It's solitary. This is per se suspicious. It is irregular in caliber. It is dilated more distally than proximal. All these are suspicious features. And with intraductal soft tissue component, lack of fluid filled, okay, anechoic, and there are foci bright, foci suggestive of calcification, and there is periductal reaction, significant periductal. So periductal reaction can also seen with acute inflammations, but all constellation of all findings are highly suggestive of malignant process. While when we compare it with this one, as we mentioned earlier, this is progressively now narrowed in caliber toward from the base of the nipple toward parenchyma distally, and even this hyperechogenicity and irregularity indicate fibrosis rather than edema and these things. Okay. Okay. The last associated feature for today's discussion is skin changes, and here we can see malignant masses, okay, in this example with focal skin thickening and retraction, V-shaped retractions, okay? And here we can see diffuse skin thickening in case of carcinomas, inflammatory carcinomas. So as we have mentioned before in anatomy lectures, we said that skin is structures with thin hyperechoic lines in between isochoic band with maximum thickness of 2 millimeters and less in periareolar region and inframammary fold, the skin can reach up to 4 millimeters. Otherwise, it's considered to be skin thickening. That might be focal or diffuse. So here we can see edematous skin thickening due to invasions of underlying carcinoma. While in this example here, can you see the skin thickening on mammography and corresponding one in this ultrasound? In a case, it is a diffuse one in a case of post-radiation, okay? So post-radiation can cause edema and can cause skin thickening. And in this example here, there is direct invasions. Can you see the direct invasion? Apart from thickening, there is direct invasions of the tumor into the overlying skin. And this skin here, there is ulcers. This is a malignant ulcers. Though you could not see the lesion here, okay, it was isochoic, but there is some extensions and by the effect, indirect effect on the vascularity causing ulcers, and the skin, it was involved by malignancy in these elderly patients. All these were my patients, are my patients, sorry. And this is from the literature, acute mastitis with abscess tracking into overlying skin thickening, one of the most common benign etiology of skin changes. And here we can see skin retraction. Do you remember this case? Okay, of periductal mastitis, we can see here retractions. And the patient has bilateral changes. That is why it is more reassuring even. Can you see the retraction in the left breast is less than that on the right breast, okay? And the lower example here, there is the mass. If we look here, we can see the nipple and we can see retraction of the nipple areolar complex. With some angulation, we could appreciate underlying mass that pulling the nipple. That was a malignant mass pulling the nipple. All these are my patients. And the teaching point here regarding the technique to see these superficial changes or to better visualize the nipple areolar complex, skin, and superficial lesions, you need to use stand of gel pad, thick amount of coupling gel, okay, and not to press too hard. Try not to press too hard, gently put your probe, okay, so you can visualize this area very clear. And you can see here, this is irregularity and pulled-in appearance or concavity of the skin in a case of retraction. Again, can you see the concavity here? Concavity. Again, this irregularity and concavity in a benign cases. This is just scarring, both surgical scarring and long-term ultrasound follow-up. And this is in a case of granulomatous mastitis, acute presentation of a granulomatous mastitis. Okay. This is the patients of the retractions of periductal mastitis. I brought all this image, both sides, just to show you the extent of this abnormality and its complications. As I have mentioned before, being bilateral, same changes, more reassuring. The lady was only 31. As I told you, periductal mastitis usually seen in young ladies. She has nipple discharge, but over long time. And the most interesting here to show you this, can you see the fistula between the duct? Can you see the duct here attached to this? And here you can see the defect in the skin, representing fistula between the duct and the skin. Okay, it is a rare complication seen in less than 2% of the cases. Okay, so the associated features are architectural distortion, echogenic rind, duct changes, skin retraction, and skin thickening. We have already discussed in these sessions, and the edema, effect of vascularity and elasticity assessment are going to be discussed in the next session, inshallah. Okay. Describe the calcification in this case, please. What is the ACR descriptors of this calcification?
Microcalcification in the large one, and also microcalcification in a smaller lesion.
Okay, it is a microcalcification, but we have main 3 descriptors. What are these 3 descriptors? Even if you did not say micro.
Mass.
Yes, this calcification,
Intraductal, intra-mass, in the mass.
In a mass. Here you have calcification in a mass. Okay, this we call it calcification in a mass. In a case of DCIS comedo type, and this type, the descriptor here, and is it? Can I ask you here? Is it suspicious or not? Before you know the pathology, the this calcification is suspicious because
the mass is suspicious.
Yes, because it is associated with a suspicious mass. It's suspicious because it is related to suspicious mass. But what about this one?
Microcalcification associated with an area of architecture. I think it is architectural distortion. This hypoechoic area.
Okay.
Hypoechoic area.
When you have, now we know there are 3 descriptors of calcifications. So we have to be confined to the ACR descriptors. Either we say calcification in a mass, calcification outside the mass, calcification, intraductal calcification.
Intraductal,
yes, this is intraductal calcification. There is soft tissue. There is soft tissue inside the duct associated with calcification. So this is just intraductal calcification. Is it suspicious or not?
Intraductal calcification is suspicious.
Excellent. Intraductal is suspicious. Whatever it is pure, the anechoic duct, and we can see calcification as you have seen in my case, or the cases from the literature with soft tissue inside the duct associated with calcification. In both situations, it is suspicious. Okay, intraductal calcification is suspicious. So this is a case of DCIS from the literature. Okay, what are the associated features in these invasive carcinomas? These 4 cases are my patients. Give me the associated.
Echogenic rind.
Excellent. Echogenic rind one. What else?
The second on the left, architectural distortion.
All are associated, all of them, not second. All of these associated with architectural distortion. Even,
Architectural distortion.
you see, I told you, ductal changes, abrasion of ductal changes is architectural distortion. Skin tethering is architectural distortion. Cooper ligament changes are architectural distortion. The echogenic rind is architectural distortion because it associated with disruption of the adjacent tissue and lack of normal tissue differentiation. So at the end, it is an architectural distortion. So all these type of architectural distortion can be applicable to these 4 cases. And even you can find the cutting. Can you see here? This one? Can you see the cutting of the tissue plane? Can you see the cutting of the tissue plane? This one?
Yes.
Cutting the tissue plane, and again here, this is a tissue plane. This extension, cutting the tissue plane and extend angulations, contour abnormality, retraction, thickening of the Cooper ligaments, straightening, tethering. It is not arc-like, it is straight, it is thickened, it is tethered, okay, disorganized. So all types of architectural distortion we have mentioned in these lectures can be seen in these examples for examples of cancer. What are the associated features here?
Skin thickening. Skin thickening, architectural distortion.
Yes, skin thickening, tethering, architectural distortion, like what?
The rind, echogenic rind.
Echogenic rind
rind.
and Cooper ligaments, okay?
And
Cooper ligaments.
this
And even here you can see a small area of V-shape skin retraction. Here, this is my patient. Can you see? Throughout it because the convex probe, low frequency probe, okay, eliminate this architecture, this extensive posterior shadowing, and you can see the whole mass. Okay, so can you see this irregular non-uniform rind? Can you see the cut of the cut here in tissue plane and the Cooper ligaments changes? Okay. Associated features.
diffuse skin thickening.
Skin thickening and skin
retraction, V-shape.
Retraction, excellent, retraction. Okay? This is the retractions. Skin edematous skin thickening and focal retractions. Okay, so in conclusion, or what we can summarize from this presentation, that ultrasound is very unique and will allow us to characterize lesions with several features such as morphology as primary sign, along with other secondary features like orientation, echo-pattern posterior feature, as we have mentioned in previous sessions. And malignancies can have benign features as ultrasound. To better characterize a lesion, you need to look for any subtle suspicious features like cutting signs. Okay? Calcification have been poorly characterized with ultrasound compared with mammography, but they can be recognized as echogenic foci, particularly when in a hypoechoic mass. However, high-resolution transducers at current use can depict fine calcification, including intraductal calcification, particularly if they are superficial, and groups of microcalcifications concentrated in fibroglandular tissue. If calcifications are recognized on sonogram will be biopsied with ultrasound guidance. The descriptors, associated features, can help in further characterization for prediction of likelihood for malignancy. However, all are secondary to shape and margin in predicting malignancy. Each alone has little specificity and should not be used as a sole feature in assessing a mass for the likelihood of cancer. But here I can say except for what, Suhair? The only exception is as an associated feature, the cutting sign. The only exception is the cutting signs. With the cutting signs, we can raise the suspicions. Ultrasound is often useful in confirming, characterizing, and localizing architectural distortion. Harmonic tissue imaging improves the conspicuity of some lesion presenting as architectural distortion. An echogenic rind is a thick echogenic halo, usually due to peritumoral edema or spicules or desmoplastic reaction or spicules beyond the resolution of ultrasound, and it's highly predictive of malignancy, is being added to the associated features in the latest editions. Skin thickening can be focal or diffuse, can be a presenting feature of both benign and malignant conditions, and finally, features of ductal dilatation that are concerning and warrant biopsy include unilateral breast ductal dilatation, focal ductal dilatation in breast otherwise normal duct size, dilated duct that not anechoic, with internal vascular soft tissue, irregular outlines, and the ducts extending from a suspicious mass. At the end, thank you for your patience and attention, and if you have comment or questions, you are welcome.
Thank you very much, Dr. Rabah, for the nice presentation. I have one question. I want to ask you about suspicious duct dilatation. You mean that is it a single duct dilatation? It is suspicious, even if with no calcification, with no any turbidity, complex masses inside the duct. You mean that this single duct dilatation or single ductictasia, it is suspicious? How I can BI-RAD it?
Okay, you are right. It is concerning. We can say it is concerning, but I cannot, a solitary duct, I should not report it as BI-RAD 4 unless at least it's supposed to be BI-RAD 3. Okay? But if there is any added associated suspicious finding, then I will upgrade it to BI-RAD 3. And even I have shown to you one of the cases. Let me show it to you back. And yes, this one. Here, this is single duct, transverse and longitudinal. And this is also single duct, okay? With fine internal echoes, but no other features suggesting that it might be malignant. So I have reported this case as probably benign abnormality, BI-RAD 3. And on long-term follow-up, okay, proven to be just a benign ductictasia. But it will, when you,
so you mean
see,
that
when you see a solitary duct, you should not take it lightly, not like in the case. If you have seen like this, it will be reassuring. It is bilateral, multiple duct, anechoic. I'll be relaxed. Okay? But if I have seen a single duct, I will not be relaxed. I have to search. I have to make sure that this duct does not indicate there is underlying malignant process. But if I couldn't find any associated suspicious features, okay, that means I will not go. Although this is from the literature. This is from the literature. They said that the suspicious features, if it is a unilateral ductal dilatation or it is a focal duct, it will be concerning. But they said may warrant biopsy. May warrant biopsy. Okay? So not all solitary dilated ducts need or warrant a biopsy. But if it is a solitary, it has to be concerning for you. You have to think about you. It might need to proceed for biopsy. But if it is not associated with internal vascularity or soft tissue component, calcifications, or surrounding suspicious features or adjacent mass or whatever, just thin walled, imperceptible wall, okay, echo-free or fine internal echoes only, just it either be, it will be just probably benign and just follow the case, okay? Huh?
Okay, thank you very much, Doctora.
Okay. Any more questions or comment? Okay. If you have no more questions, even in the chat, there is no questions.
In the chat,
So here,
no. In the chat, no questions. So if no question, you have to conclude the lecture.
did you
Any
review the
question?
chat? Did you review the chat?
Yes. Yes, I review the chat.
Okay, no
Yes.
questions? Okay. Thank you very much. Let us see you, inshallah, next week.